A very good evening to all as we get into this session, which is one of the most prestigious and most looked forward to sessions in the annual conference of the Chandigarh Ophthalmological Society, that is the Dr. A.D. Grover Memorial Oration. I will straight away go on to the introducing the Dr. A.D. Grover Memorial Oration, and it's my proud privilege and honor to be doing this. And now, sir, Dr. A.D. Grover was the president of the Chandigarh Ophthalmological Society, which in 1985. He was also the president of the Indian Medical Association Chandigarh State Branch between 1981 to 82. Can I have? Yes, so just a little bit about his early life. He was born on the 1st of March 1928 in Miawali, West Punjab, to Shri Bhogaram and Srimati Pyaribai. Sir finished his primary education in Okra, and for his secondary education joined DAV College Lahore and passed his FSc there. For his medical education, he was initially admitted to the Balak Ram Medical College Lahore initially, but after partition in 1947, he continued his medical education in King George Medical College Lucknow. He passed his MBBS with honors in 1951 and MS in 1955 from KGMC Lucknow, and finally settled in Chandigarh in 1960. In his professional life, his life was exemplary from 1956 to 1960. After a short stint in Jaunpur at the Sitapur Eye Hospital, he joined the Gandhi Eye Hospital in Aligarh as an assistant professor in charge of the research wing. After a few years, he was invited to help set up the department at PGIMR Chandigarh, which he did very ably. But after that, in 1962, he went on to start the first private hospital in Chandigarh, where he was the medical director and chairman of the Grover Eye, Laser and ENT Hospital. Dr. A.D. Grover sir's salient work included extensive research on trachoma while at Aligarh, and notably his work on molluscum contagiosum was acknowledged in the ophthalmology book series of Sir Stuart Duke Elder. A philanthropist at heart, he held numerous surgical camps in Punjab, Haryana, and HP, and also participated in the first eye camp held by the Lions Club in Chandigarh. In 1983, his social work extended to the tribal areas near Ranchi, to the interiors, like places like Chota Nagpur, Lahore, Daga, and Khunti, where in fact, for the first time, the tribal people who were possibly not aware of the medical care available were made aware of, for the first time, that cataracts were curable. And his spirit of philanthropy was imbibed and carried forward by the Dayanand Foundation, who carried on his work and established a hospital in his memory. Now, the mark of a leader, there are various dedications to Dr. A.D. Grover's name. There's a lecture hall in the IMA building in Chandigarh, which is named after him. The Dayanand Foundation has established a eye hospital in Khunti near Ranchi in his memory. And the Dr. A.D. Grover Memorial Oration was instituted in his memory. We have had a list of worthy speakers and ophthalmologists who have been awarded this oration, starting from Dr. L.P. Agarwal to the present leaders of the current times, Professor Jagat Ram, Professor Amod Gupta, Dr. Bhujang, Dr. Mahipal Sachdev, Dr. Santosh Nawar. And this year, the oration is being conferred upon Dr. Ken Nischal. I would now invite Dr. Jaspreet to please introduce the awardee of the Dr. A.D. Grover Memorial Oration. You can stop sharing the screen.
Good evening, Dr. Nischal, and good evening to all the panelists and delegates who are viewing this annual conference of Chandigarh Ophthalmologic Society. It's my proud privilege as president of Chandigarh Ophthalmologic Society to introduce to you Dr. Kamal Nischal, who is the awardee of the Dr. A.D. Grover Memorial Oration today. So he is a name in the world. He's the chief in the division of pediatric ophthalmology, strabismus and adult motility, director of the pediatric program unit at the UPMC Eye Center in Pittsburgh, and a professor of ophthalmology. He was born in Nairobi in 1964, but his father was from Dera Baba Nanak and mother hailed from Gujarat near Lahore. So his roots are here. He's the youngest of the 10 siblings, but at a young age of 6, he moved to the United Kingdom. And there he did his ophthalmology residencies at Birmingham and Midlands and the Oxford Eye Hospital in the United Kingdom. Thereafter, he did his pediatric ophthalmology fellowship at the Sick Children Hospital in Toronto. He was Kamal Nischal, but his name Ken was given to him by his mentor and friend, Jack Kansky. Well, you can see here some other photographs. I mean, he enjoys his life there. He's one of the pioneers of pediatric corneal transplants. His main areas of clinical research are anterior segment development anomalies affecting the cornea, lens, and trabecular meshwork. And we've seen a lot of publications on this from his part. And he's also the member of the scientific advisory boards of the Pediatric Glaucoma and Cataract Family Association. And one of the big achievements in his career is what he started with is the World Society of Pediatric Ophthalmology and Strabismus. So he is the founder with his friend and his brother from another life, which is David Granite in 2009. So this all started after a chance meeting in 2008. So he said they just had probably a meeting of one day. The next day, probably they came out with this plan, we have to start this. So that's something great. And the way it's World Society of Pediatric Ophthalmology and Strabismus has contributed to the world, to literature in this world on the diseases in children, I mean, it's creditable. But at heart, if we see, he's still a Punjabi. He could teach Bhangra to his colleagues there in US. He enjoys sarson ka saag and makki di roti, and also has a sweet tooth for gulab jamun. Well, he used to visit us, I know, before the pandemic. So whenever he gets time, probably he just make it a point to come over. And yes, his family, he has a charming wife, Anita, which you can see in the photograph, and is blessed with 3 lovely, talented children, Parus, Roshni, and Jeevat. And with this, I now invite Dr. Ken Nischal to please deliver the oration talk. Thank you. Where do I share it?
Thank you very much indeed. While I'm sharing my screen, I want to say that I am overwhelmed by the honor bestowed to me today to give this, well, I don't know what to say really. I think it's probably one of the most important eponymous lectures I've ever given. So I thank you very much. And it's important to me because I see the people who have given it before. I see what Dr. A.D. Grover contributed to Chandigarh and Indian ophthalmology, and this means a tremendous amount to me. Thank you so much. So these are my disclosures, none of which are relevant today to the talk that I'm going to give. I was asked to talk about the approach to the child, and I know that there are many excellent ophthalmologists, glaucoma specialists who deal with children who have pediatric glaucoma. And what I wanted to do was I wanted to give you my approach, a slightly different approach to how this might work, you know. And some of these people talk about pearls. I like to talk about diamonds, and no matter how small those diamonds are, they still sparkle if you can remember 1 or 2 of them. So I hope that the more junior members amongst the audience will remember 1 or 2 diamonds, no matter how small they are. So when I see an infant, I always take the infant from the mother and ask if I can hold the infant, and I cuddle the infant. Why do I do that? If a child has glaucoma, that child's going to be with you for the duration of their early years until they become an adult. And there comes a time when they don't want to be examined by a doctor. So when you hold them close in the nascent period, that's in the first few months of life, or even in the first year of life, they lay down a sense of smell in their amygdala. And here's a paper that shows very clearly that children who smell somebody in the nascent period, get their scent, they allow them to examine them or approach them much more easily. So this is a trick so that when they get to the terrible 2s, I can examine them more easily. This talk is not really going to be about surgical technique. I'm going to show you some surgical techniques, and these are all the options that you have. But I mean, in congenital glaucoma, medication can be used, but you're temporizing. In juvenile glaucoma, of course, medication is very important. But one of the things that's worth remembering is that all of the medications that we have, their safety and effectiveness in pediatric patients was never established by the companies because it just wasn't feasible. And so, you've got to make sure that you understand that a lot of what you're doing is off-label, off-license use. And so remember the same thing, you're looking for target pressure, look at the whole picture of the eye, start with one drop and then use injective therapy if needed, and always do punctal occlusion in the younger children, because you want to avoid systemic side effects from absorption into the nasal mucosa. And it's a simple thing. It's easier to get the parents to pinch like that than to do this. So you put one drop in each eye and get them to pinch the nose for 10 seconds. And it sounds like it's an extra thing to do, but if they get asked to do it, they will do it. So always treat the child as a whole. Now, what do I mean by that? Many of you will recognize instantly that this is gonioscopic pictures of a child with Axenfeld anomaly. You can see the iris processes going to a prominent Schwalbe line. And here are two different patients, one with a very prominent posterior embryotoxon at the bottom here, on the bottom left, and correctopia, and another patient who doesn't have posterior embryotoxon, but has very flat, featureless iris that's dark, which is due to iris hyperplasia. Both of these children, so here's another one with posterior embryotoxon, both of these children, and here's another one with partial aniridia due to Axenfeld-Rieger anomaly, have Axenfeld-Rieger syndrome. So they have hypodontia, they have a flat cheek, so maxillary hypoplasia. And when you look at the belly button, they have the outie belly button, which is a periumbilical hernia. Here's another child who has also corneal opacification, which can happen in Axenfeld-Rieger syndrome, but they have the syndrome. And you might say, okay, so what? Well, there are two genes that can cause Axenfeld-Rieger syndrome, or Axenfeld-Rieger anomaly even, PITX2 and FOXC1. It depends on the mutation as to whether you get extraocular features or not. But here's the really important thing. If you have a child who has Axenfeld-Rieger anomaly and you look at the face and they have maxillary hypoplasia and they have hypodontia and they are short for age, that's going to be PITX2. Because PITX2 can be expressed in the pituitary, and you need to get that child to an endocrinologist or a pediatrician. Otherwise, they're going to end up being short for the rest of their lives, and you're going to miss the opportunity of changing a child's life. I was in Seattle last week, and I went to Seattle because my sister used to live there. And my sister, who unfortunately has passed away, said to me once, she said, what you do as a pediatric ophthalmologist is not for tomorrow, it's for decades to come. So when you see a child, you see that child not for today, not for tomorrow, but for decades to come. And that's the responsibility that we hold as pediatric ophthalmologists. So here we have a child with aniridia. Many people know about the association I'm going to talk about. If you have a family that have aniridia because it's autosomal dominant, you don't have to worry about very much outside the eye. Here's the foveal hyperplasia. But what you do have to worry about is if it's sporadic, it could be a deletion. Now, even in autosomal dominant cases, there has been one case reported in a family who had autosomal dominant aniridia, but they actually, the one child ended up having a deletion as well as an intragenic mutation. Now that was very worrying because normally if it's autosomal dominant and there's a family pedigree, we don't worry. So it means that you still have to be aware of that possibility. But if it's autosomal dominant, I don't normally do the testing if the testing is difficult to do. In the United States, it's easy, it's cheap, we do it. But why is this a problem? Well, the problem is that on the 11p13 where PAX6 sits, you also have the Wilms tumor gene, which is a tumor suppressor gene. So if you miss one copy, then you can get a somatic mutation that can give you the tumor. Okay, that's important. And if you don't have genetic testing, what can you do? And I'm going to talk to you about that. I want you to look at these images, though, and I want you to see that in aniridia, you have a remnant of iris. And that remnant of iris over time can turn up close the angle, and cause glaucoma. Remember that, because I'm going to talk about it in a second. So this is what Wilms tumor looks like. Obviously, it's a serious condition. So if you don't have access to testing, then they need a renal ultrasound scan every 3 months until 5 years, every 6 months until 10 years, every year until 16 years. And then if you find they have a chromosomal deletion, then every 3 months they need a renal ultrasound scan. So it's onerous. Okay, so we've talked about, approaching, how do you deal with a baby? Cuddle the baby, make sure you, in children, occlude the punctum. We've talked about approaching the child as a whole. Well, what about modifying my approach? There is a Japanese art form called kintsugi. Kintsugi is the art form where you take pottery, you break it, and then you put it back together and you paint the fracture lines. And the ethos of kintsugi is that you embrace the flaws and imperfections so that you create an even stronger or more beautiful art form. And I think about pediatric glaucoma like that we have what we do in adults, and we get trained that you must do this, this, and this, and this. But the imperfections and the flaws of being able to examine a child, or what the child's behavior is, or what their social circumstances are, which has nothing to do with them, but their parents, they affect how you put that art form together. So I think of pediatric glaucoma as kintsugi. So here are all the options that we have: medication, goniotomy, trabeculotomy, trabeculectomy, combined cycloablation, and tube surgery. In refractory glaucoma, aphakic glaucoma, or glaucoma where a combined trabeculectomy has failed, glaucoma drainage tubes are considered to be the gold standard. But I want you to think about the toddler who has a constant runny nose and rubs his eyes all the time, and think, okay, I might be doing the right thing by a textbook, but am I doing the right thing by this child? Am I going to put this child at risk of an endophthalmitis where he loses his eyes? And let me tell you why I'm so passionate about this. In 1999, when I went back and I was a consultant at Great Ormond Street Hospital Children, I automatically got a large private practice from all over Europe. And a child came to me from Malta who had bilateral congenital glaucoma, and somebody had been treating him with cyclodiode laser. And he was photophobic. And I said to mother, look, the thing to do is put tubes in. And I put tubes in both eyes. And for the first time, he's opening his eyes. His mother's happy. What I did not recognize was that he had a runny nose. And this boy, who was 3 years old, was touching every part of his body and then rubbing his eyes. He goes back to Malta. And I'll never forget this. On a Saturday morning, I'm sleeping. I get a phone call from the Maltese High Commission saying, the boy's got his eyes closed. We're flying him back. And when I saw him, he had bilateral endophthalmitis. That's 4 months after I'd put tubes in his eyes. And both eyes were lost. A toddler who has a constant runny nose and rubs his eyes is not the ideal person to put a tube in. A child who will not let you examine them at the slit lamp is not the ideal child to put a tube in. Social circumstances, meaning that there's going to be poor follow-up. It's better to do cyclodiode laser than put something in the eye that's a foreign body and not be able to follow it up. And if a child has a shallow anterior chamber, put a tube in and then be prepared to give that child a cataract. Or even worse, let me show you. This is a child who was sent to me from another center in the United States. The child is the worst child you could try to examine. She would not open her eyes. So they could not see that a tube had been put in and there was a melt occurring. Only at the very last stage where the child wouldn't open their eyes, they take her for EUA, took the tube out, and then they sent the child to me and said, well, can you help us? And I was able to do a tectonic graft. Here's a child who had a shallow AC, had a tube put in when he was 6 months old. The tube rubs the cornea, he gets ectasia. We have to think about the child as being a dynamic individual, right? And so it's important, it's always important that we're not missing out on things. Okay, so how do we avoid these difficulties, right? We have other parameters. We have cyclodiode laser, we have combined trabeculectomy, trabeculotomy, and we have goniotomy. What can we do? This is a paper that I published with Amanda Way, who was my resident at the time. I use high-frequency ultrasound. Here's an example of high-frequency ultrasound to delineate the Ciri body and the Ciri processes. And what you can do is traditionally we transilluminate to find these. And in some children, especially in aphakics, the transillumination is more posterior than you would expect. And you can end up giving them a retinal detachment, which has been reported in series of pediatric glaucoma being treated with cyclodiode laser. But with the high frequency ultrasound, you can delineate exactly where it is, deliver the laser. And by the way, on your bottom right here, that's what a pop looks like immediately after you've done it. And this is what a non-pop looks like. So you get expansion of the Ciri process. And what this does is, what I found is that you can do 180 degrees inferior cyclodiode laser 3 times before you have to do something invasive like put a tube. But you can buy 2, 3, 4, 5, 6 years of time, and the whole behavior of the child changes. What about combined trabeculectomy, trabeculotomy with antimetabolite and releasable sutures? Well, this is the first paper that was published by my group, and we found that we had 88% control. In 88% of cases, we had control at 5 years. But if it was a secondary glaucoma, aphakia or pseudophakia, that dropped to 50%. So still, tubes are still something that you had to consider. But if you have a child who has all those parameters I talked about, do the trabeculectomy and trabeculotomy with mitomycin C and use a releasable suture. And then recently, I've been blessed to have 2 amazing fellows, Jamila Hayasat and Amgad Eldib, who now we've appointed our faculty with me at Children's. They did this audit, and what I want to show you is this was our outcome compared to other outcomes of trabeculectomy with or without trabeculotomy and mitomycin C. But this is another approach to the child. What we found was the conclusion was that visual rehabilitation is crucial for patients with congenital glaucoma, and despite a good intraocular pressure control post-operative visual acuity was poor in this group because they all presented with Harb's-Tree right through the visual axis. So let's not stop there. If we have that, then we should think about doing DSEC for these children. And you can take a child here, bottom left, with a Harb's-Tree right through the middle and turn them into one with no Harb's-Tree. We have to think outside the box. What about goniotomy? The image on your left is a 4-month-old who's perfectly normal. So you've got the iris root, you've got the Ciri body band, you've got the trabecular meshwork. On the right, this is a child with primary congenital glaucoma. So in a normal child child with primary congenital glaucoma, this is the technique that I use. And here is a goniotomy. I know that glaucoma cases that present in Chandigarh are often much more severe. But if you can clear the cornea and you can do either a trabeculotomy or preferably in my hands, a goniotomy, it's a great way of controlling glaucoma. And I'm showing you this in a child with primary congenital glaucoma, but what I want to show you is that you can take goniotomy and use it in other circumstances, either to buy time or to treat the glaucoma that you're dealing with. So you can see the cleft here being formed. I use a Barker and Hoskins lens, and I'm using a disposable 25 gauge needle, and I have some Helon in it. Actually, it can be any viscoelastic. I have no financial interest in Helon, but that's what I use. So there's your goniotomy. Okay, standard goniotomy, not much news. This is what it looks like after you've done the goniotomy. You get that recess and you get exposure not only to the meshwork, but the uveal tissue. Okay. David Walton, in my opinion, is one of the most amazing contributors to pediatric glaucoma. He was an adult glaucoma surgeon who did a lot of pediatric glaucoma, and he wrote this paper about goniosurgery for the prevention of aniridic glaucoma. 55 eyes, aniridia without glaucoma, 91 procedures, average of 200 degrees of goniosurgery, and 49 of them had no glaucoma as a result. So think about this, prophylaxis. Remember that image I showed you? If you can open this angle up here on the top left or the top right so that it sits back like I showed you it does when you do a goniotomy, you can prevent or control the glaucoma, but you have to do it early. So here is a video of a child. I do prophylactic goniotomy in aniridic children. If they have a family history of glaucoma, it's easy to convince the parents. If they don't, it's a little bit more difficult. The worry, of course, is you're going to hit the lens. And it's a psychological worry, right? You're going right across the lens. So you've got to be comfortable in doing goniotomy. Here is a child with aniridia who has iris remnant. And look, when I cut those strands, how it sits back. And every child I've done so far has not needed a tube or a trabeculectomy or cyclodiode laser. They've needed drops sometimes, but not anything more invasive. So why do we put children through more invasive things when a simple goniotomy can help you control this pressure long term? And you can see it sits back really very well. And you can see why you are now preventing that angle closure type of glaucoma that occurs. Okay, let's look at goniotomy for aphakia. This is, I think, a really nice paper, and they showed that basically that you could do goniotomy in aphakic glaucoma and prevent having to put a tube in or other further surgery. But the question is that can't be true for every type of aphakic glaucoma, surely. What I found in my hands, here's a child, one eye, the upper picture is normal, the other eye had a cataract, congenital cataract due to PHPV. Now, child had lensectomy and started to develop glaucoma. But if you look at this eye at the bottom, there is an acquired iris ectropion. Why? Because there's a membrane developing here. And the membrane, I'm going to put my pointer on for here, laser pointer, the membrane goes into the angle. This is the ideal candidate to do an aphakic goniotomy because you're exposing the meshwork, which is being blocked. And so I would say to you that it's worth doing not only a temporal approach, but a nasal approach goniotomy in these cases. And you can control the glaucoma, at least delay significantly by a number of years, the tube that you have to put in. Now, I don't want anybody to go away with the impression that I don't like tubes. Tubes are great. They're really important. It is the child in front of you that determines whether tube is great at that age or whether you have to let the child get older to understand what you're doing, to be able to examine the child more appropriately. So, approach a child as if he or she were your own. Yeah, you can put a tube in this child, but is that what you want to do if this was your own child? Knowing the complications that occur if a child is rubbing their eyes, has got a runny nose, has got a shallow AC, not going to be able to examine them. Is that what you would do? Just because a textbook says you should do something, make sure it is the right thing for the child in front of you. You know, there's a couple of sayings that I'd like to share with you. The one that I like the most is, there is no wrong time to do the right thing. There is no wrong time to do the right thing. And I think that's an important thing for us as pediatric ophthalmologists or ophthalmologists who deal with children to remember. The other thing is something that I said at a graduation ceremony years ago, and I want to share this with you. And what I said was, the point is there is no point. There's only a continuum. While a glance into the past tells us where we came from in terms of who we are and what we have learned in pediatric glaucoma and how hard it has been or may have been and the lessons that we've learned, it is only our ability to imagine that disrupts our present to shape our future. And it's clear to me that Dr. A.D. Grover had that imagination to disrupt his present to create his future and our present. And on that note, I can only thank you sincerely again for allowing me to be the A.D. Grover Memorial Lecturer. Thank you so much.
Thank you.
I'm trying to stop sharing, but I can't manage to do it. There we go.
Yeah, that was an amazing talk. I mean, on pediatric glaucoma, and those fantastic videos. I mean, gave us a lot of insight into what really how the child should be managed. I mean, really something you can say creditable you are doing for these little children with the glaucoma. I mean, no doubt at all. I mean, thank you so much for this lovely talk. And in the august presence of our Head of Department, Dr. S.S. Pandav, and Dr. Dogra here, Dr. Rohit Grover, and our Secretary, Dr. Chintan, and other delegates, panelists, I would like to now present to you the Oration Award that is from the Chandigarh Ophthalmologic Society in the conference in the 33rd annual conference which we are having at the moment. Thank you so much, Dr. Ken Nischal.
Thank you, thank you. I hope you won't mind. मैं पंजाबी बोलते हैं ਅਸੀਂ ਤੇ ਇੱਥੇ ਚੰਡੀਗੜ੍ਹ ਤੇ ਇਸ ਤਰ੍ਹਾਂ ਦਾ ਲੈਕਚਰ ਦੇਣਾ ਡਾਕਟਰ ਏਡੀ ਗਰੋਵਰ ਦੀ ਮੈਮਰੀ ਵਿੱਚ ਤੇ ਮੈਂ ਬਹੁਤ ਖੁਸ਼ ਹਾਂ. Thank you very much.
Thank you.
Thank
you
you
have
so
a
much.
round of applause here.
Thank you. A round of applause.
Absolutely wonderful, mesmerizing, in fact.
I'll put in a line, or Dr. Ken put in some wonderful words. And one thing, yes, great people don't do great things, they do great things simply, or they make the simple way to do great things. So that's what we learned from his lecture. Has given us some really good perspectives on pediatric glaucoma.
Absolutely wonderful. Very nice. Yes, and thank you. Then we conclude this session of oration, and we'll move on to our next session on pediatric ophthalmology and strabismus. And yes, Dr. Nischal, you are most welcome to stay on, and we can have your expert comments.
I will go off just for a few minutes. My daughter is going to DC today. She's moving out of the house for the first time. So I have to make sure I say goodbye to her, but I will come back.
Thank you so much.
Thank you.
Thank you. Bye.
Thank you. And welcome all other panelists and speakers for this session. While